Assalamu alaikum wa rahmatullahi wa barakatuh. Peace be upon you all. I'm Hani Mahmoud from Egypt. I'm going to speak today about the 2D, 3D-TEE rule during MitraClip procedure. As we all know, percutaneous valvular interventions have become an important alternative therapy for patients having surgical high risk. Particularly, MitraClip percutaneous therapy had been proven to be feasible and effective in patients with severe or moderately severe symptomatic mitral regurgitation who were rejected from the surgeons due to their surgical high risk. We have two categories for mitral regurgitation that can be treated using MitraClip procedure. The first category is a degenerative mitral regurgitation. When we say degenerative, we mean the flail or prolapse of the mitral valve. But we have some anatomical feasibility criteria that were developed at the beginning of the experience of such interventions. Now we are more expert and we can overcome some of these anatomical features. But in order to start a program, we have to be highly selective till we build our own experience. The first feasibility anatomical feature of the flail mitral valve is to have a flail gap that is not more than 10 millimeters in height between the tips of both leaflets, like in this view. And from the short axis view, we can see the flail width, which is here illustrated here in this very nice illustration. This flail width shouldn't be more than 14 millimeters. That means 15 millimeters was a relative contraindication for MitraClip therapy. But as I said in the beginning, that was in the beginning of the experience. Now, with the increased experience of such intervention, as long as the mitral annulus is big enough to accommodate more than one MitraClip, now we are going for larger flail width, even 20. And we can put 1, 2, 3, in some aggressive centers, they can put even 4 to 5 MitraClip side by side, provided the mitral annulus is large enough to accommodate more than one MitraClip without creating iatrogenic stenosis. The second category of mitral regurgitation is the functional mitral regurgitation. And here again, we have to have coaptation depth, which is the distance between the imaginary line of the annulus and the coaptation point of both leaflets. We have to have this depth less than 11 millimeters. But again, with the increased experience, we are going for longer depths. On the other hand, the anatomical criteria, which is still holding till this moment, is the coaptation length, which is the actual coaptation between the two cusps. We have to have at least 2 millimeters of coaptation between two leaflets, because this coaptation will help the leaflets to fit inside the clip during the grasp. If they are too much away from each other, it will be too difficult for the small clip to grasp them both at the same time. The German experience is the biggest experience with any kind of structural interventions, particularly the MitraClip therapy. They developed very well-written criteria for the suitability for mitral valve in terms of the feasibility for MitraClip procedure. We have the optimal valve morphology, and we have the unsuitable valve morphology, and we have the gray zone in between that will depend on the experience of the operator. The optimal valve morphology, if we have a central pathology, scallops 2, A2 and B2, no leaflet calcification, mitral valve opening area more than 4 centimeters square to avoid creating stenosis, mobile length of the posterior leaflet of more than 10 millimeters, the coaptation depth, as we said, should be less than 11 millimeters, normal leaflet strength and mobility, the flail width shouldn't be 15 or more, and the gap shouldn't be more than 10 millimeters. And we have the unsuitable valve morphology, which is perforated mitral leaflets. Obviously, clipping of the mitral valve will not treat the perforation or the cleft. And the severe calcification, if it is in the grasping zone, but if it is outside the grasping zone, that can be accepted more or less. The hemodynamically significant mitral stenosis, because we are creating stenosis, so we shouldn't have a valve opening area of less than 3 centimeters square to start with. or a mean gradient of more than or equal to 5 millimeters of mercury, the diastolic mean gradient of the mitral valve. The mobile length of the posterior leaflet shouldn't be less than 7. If it is 7 or less, this is unsuitable for mitral valve clipping, and the rheumatic leaflet thickening for sure, because it is restricted in systole and diastole. And lastly, the Barlow's syndrome, which is the multi-segmental flail leaflets, which is not going to be treated with 1 or 2 clips. We will have to clip the whole coaptation length, which is not a good idea. This is the whole system of the MitraClip assembled outside the body. This blade will be fixed to the right side of the patient on the table, and here's the handle here, and these are the controls for rotation, right and left, anterior and posterior, lateral and medial, and this is the sheath which will be introduced through the right femoral vein of the patient. Again, this is the handle for the controls, and this is the clip itself. These are the arms of the clip. These are the grippers of the clip. Between the arms and the grippers, the native mitral leaflets will be grasped here and then sandwiched to form proper coaptation. And this part is like a needle, and we will see later on that we have to monitor the motion of this needle after release of the clip. This animation was made by the manufacturer of the MitraClip device. This is after transseptal puncture. The guide catheter is here, and this is the sheath, and this is the clip in closed position. Mitral valve is down, left atrial appendage, comedian ridge, left upper pulmonary vein. Now they will open the clip to make sure that the arms are perpendicular to both leaflets at the same time, and then it shows you here the navigation of the sheath from left to right, anterior to posterior, and here the rotation as well to make sure that it is really perpendicular to the mitral valve leaflet. Because if we grasp the leaflets in an oblique fashion, we will wrinkle the whole system, and obviously we can make the mitral regurgitation worse. Here, after they put the color, to make sure that we are really grasping the area of the maximal regurgitation, hopefully to reduce mitral regurg. And here, the assessment of the grasp, and then falling back, grippers down, arms up, and then sandwiching both leaflets to create the double orifice mitral valve. Before transseptal puncture, as an echocardiographer, especially if you are utilizing the 3D echocardiography, we will have a very good opportunity to look for the whole mitral valve in one view from the left atrial perspective. This view is what we call it the surgical view of the mitral valve. Surgical view because this is the view that the surgeon sees when they open the left atrium. Mitral valve is here, anterior mitral leaflet, posterior mitral leaflet. If this is the lateral, means left atrial appendage should be here, and here is the lower part of the interarterial septum. Anterolateral commissure, posteromedial commissure of the mitral valve, A1, A2, A3, P1, P2, P3. P for posterior, A for anterior. On the other hand, you can see colorful volume for the mitral valve, 3D with color to appreciate how much the regurg is occupying from the coaptation length. And here you can put this volume into the MPR mode, multiplanar reformatting or reformation mode, which will give you 2D views from the 3D volume, which is here. Put your lines exactly at the ostium of the mitral valve during systole to get the short axis view here, and then you will have what's called 3D vena contracta area. You can trace it. This is the regurgitant orifice area on direct vision. This 3D vena contracta was shown to be very well correlated with the severity of mitral regurgitation, and also I've done some work in that, and we could show that it can predict the number of mitral clips needed during the procedure. And we could show that if the vena contracta area by 3D is 0.2 centimeters square or more, this patient more likely will need more than one MitraClip. At the same time, if the length of the vena contracta area is more than 1 centimeter, this patient more likely will need more than one MitraClip. This is very important because if you know that the patient will more likely need more than one clip, you have to have at least 2 MitraClip devices on board before you start the procedure. And another point also is grasping in the medial part of the coaptation line is much difficult than grasping on the lateral part. So if you know that you will put more than one MitraClip, you start by the difficult one first to make it easier for you to grasp on the lateral side. So that helps really in planning of the procedure. Looking to the mitral valve orifice from the left ventricle, here this is a colorful volume for the mitral valve from the left ventricular aspect. You can see a central regurgitant orifice. That means grasping should be at the central part of the mitral valve A2 and B2. On the other side, you can see another patient with a medial jet. So grasping in the middle will not help this patient. Here we can say that we should grasp medially. And the other hand, and this another patient, this is another patient with a huge lateral jet and a small tiny medial jet. That means grasping medially or in the middle will not help this patient. So this patient needs lateral grasp. So understanding the anatomical orientation of the regurgitant orifice will help you a lot in the strategic planning of the procedure. 2D views is very important, of course, and we have to exclude at the beginning any pre-existing pericardial effusion before we start, because this procedure will need a lot of manipulations. A lot of wires will be in the right side, left side, may accidentally go to the appendage, causing perforation and tamponade. So you have to exclude the presence of any degree of pericardial effusion before you start, because if you notice any accumulation, you have to warn the interventionists that we have here a new pericardial effusion. Also assessment of the anatomy again by 2D, measuring the coaptation depth and length and so on, what we said, and assessment of the mitral regurgitation severity. X-plane is very helpful as well. It is not a 3D mode, but you will not be able to do X-plane unless you have a 3D-TEE probe. This is the commercial view. The atrial appendage is here, comedian ridge left upper pulmonary vein. So here is lateral, here is medial. By putting your X-plane line exactly in the middle, you will get A2 and P2 in long axis. So this jet was central from lateral medial perspective, but it was posteriorly eccentric from the anterior posterior perspective. Assessment of the left atrial appendage. This is very important. A lot of those patients have atrial fibrillation because they have left atrial hypertension, so they are very liable to have thrombosis inside the left atrial appendage. Assessment of the left atrial appendage and exclusion of the presence of any thrombi inside the left atrial appendage is quite important, because the wire, as I said, may accidentally go inside the left atrial appendage, causing dislodgement of any thrombus with its very bad sequelae that we all know from CVA or strokes. Here's the 3D volume for the left atrial appendage ostium. You can see it is more or less oval. It is not a circle. This is the comedian ridge. This is the left upper pulmonary vein. Anterolateral commissure of the mitral valve. This is A1 and this is P1, and here's the aortic valve. It looks like a long axis view. The aortic valve, aorta is here, mitral is here, with some depth behind. So use this volume, put it in the NPR mode, few seconds before the procedure, and scan the appendage from side to side. How many lobes? Is there any thrombi in the lobes from one view? During the procedure, this is the setup of the procedure. This blade is fixed to the bed, as I said, and this is the system outside, the two operators, and the sheath or the catheter is inserted through the right femoral vein. And here's the echocardiographer. The probe is here. And my advice to you is to get a fluoroscopy screen for you as an echocardiographer to look to the steps of the intervention to be harmonic with the team. Trans-septal puncture. This anatomical illustration is very nice indeed, and it shows you the right aspect of the interatrial septum. Here they remove the right atrial wall from the view and looking to the interatrial septum on direct vision, anatomically oriented. Superior vena cava is here, inferior vena cava, aortic valve, so this is anterior, and here is posterior. Here is the fossa, coronary sinus, and looking to this will help you to understand anatomically oriented view of the interatrial septum. We will do the same using 3-dimensional TEE, but let's go for the 2D first. If you are using 2D TEE, you have two basic views to start with: bicaval view, Here is the left atrium, right atrium, superior vena cava, inferior vena cava, cresta terminalis, right atrial appendage. That view will show you the superior-inferior relationship or portions of the septum. On the other side, the short axis base view, which is always between 40 and 60, will show you the anterior short axis view of the aortic valve and the posterior part of the septum. For the MitraClip, we need to puncture at the superior portion from this view and in the posterior portion from that view. As a rule, any septal puncture at any procedure, you need to stay away from the aortic root, because if you are very close here, you can puncture the septum and go and puncture the aortic root, which is not a good idea to do. So we have to be in the posterior part of the septum, but from the superior-inferior relationship or aspect, some procedures like the MitraClip will need to be in the superior part of the septum. Some other procedures like the left atrial appendage closure or the mitral balloon valvuloplasty need to be in the inferior part of the septum. By the 3D-TEE, we will get the anatomically oriented view for the live guidance of the septal puncture. Rattle maneuver is a maneuver that we proposed and we have published this. Rattle stands for rotate anti-clockwise, tilt left for 90 degrees. Rattle. Starting from the bicaval view, superior vena cava to the right. As I said, the idea is to get the anatomically oriented view for the septum from the right atrial side. So superior vena cava is here. We need to make it superior, really superior, and we need to look from the right atrial aspect. So activate the 3D zoom mode of the machine. The screen will be divided into two smaller screens. Optimize your boxes of the 3D zoom exactly at the ostia of the vena cava. Exclude the right atrial wall. We need to have a view like the anatomical illustration that remove the right atrial free wall. So we will exclude the right atrial free wall and put our lines and box exactly at the ostia of the vena cava. And on the other side, we will include the whole length of the septum, posterior part of the septum, and the aortic valve, and then acquire. It will give you a live 3D zoomed view for the septum with the same orientation of that one. So left atrium is still here, right atrium is still down, and superior vena cava is to the right. So rotate anti-clockwise, RA, rotate anti-clockwise, bring the superior vena cava upwards, and then tilt left. We need to look from here, from the right side. So tilt left the whole volume, you will have a clear view for the septum from the right atrial aspect. This is how we do it in real life. It does just take about 19 seconds. This is the bicaval view, as we said. Superior vena cava is here, and then apply the 3D zoom. Put your lines at the ostia. Acquire superior vena cava is here. Rotate anti-clockwise, RA, and then tilt left for 90 degrees, and that's it. This brown color is the blood intensity. Decrease the gain down, and you will get a clear view for the interatrial septum from the right atrial perspective. And that patient had an ASD, so it gives you an idea about the anatomical orientation of the ASD as well. With some backward tilting, you will see the superior vena cava opening. With some forward tilting, you can see the IVC, Eustachian valve, coronary sinus, aortic valve is here, and here's the aortic root. So direct vision for the septum, as I said, anatomically oriented view from the right atrial side, and this is live that can be used during monitoring of septal puncture. This is the unfair comparison between the 2D and the 3D-TEE. During septal puncture, here is the catheter introduced from the IVC towards the SVC. So the interventionist can see the catheter, can see the fossa, which is the faint part of the septum. Aortic valve is here, the aortic root is here. So you can see everything from one view without even looking to the fluoroscopy. This is during the tenting. This catheter was pointing anteriorly, and he rotated clockwise to tent the septum in the middle of the fossa. You can appreciate the tenting by tilting this volume to the right, and appreciate the tent here, and even from the left atrial aspect by more tilting of the volume. Here is another patient during the tenting. You can see the catheter impinging on the septum on direct vision. Aortic valve is here, aorta is here, and here's the superior vena cava. So it really helps in guidance of the septal puncture, and we have published this as a proposed maneuver to guide transseptal puncture using real-time 3D-dimensional echo pilot study. After the tenting, you can check from the pi-atrial view that usually comes from the 0 degrees view, then widen your sector of the 3D zoom. Usually use a 3D zoom because this is the live mode of acquisition that helps you to monitor live events in the cath lab. You can see the catheter is coming from the right side, tenting the septum, mitral valve is down. You can see everything from one view. Once you're tented, you have to make sure by the 2D again that you are away from the aortic valve, and then measure what's called the tenting height. At the 0 degrees, get the 4-chamber view and measure the height between the tent and the annulus line, which is usually should be around 4 centimeters. We need to be around 4 centimeters from the annulus because we need a distance that is good enough for us to navigate with the sheath, but we shouldn't be too high, because if we are too high and we bend the sheath, we might not be able to go inside the left ventricle in order to grasp. And if we are too low here, very near to the annulus, we will not be able to navigate the sheath and go inside. So we need a 4 centimeters distance. But sometimes if the tenting of the mitral valve is too big and the mitral coaptation is here, we need to be a little bit down, so maybe 3.5. And in some other cases, if it is degenerative, prolapse or flail, and the coaptation is here, we need to go a little bit higher, 4.5. But 4 centimeters is an acceptable height in most of the cases. Here, if you are satisfied with the tenting height, we go until the interventionist go ahead and puncture the septum. This is the characteristic sawtooth appearance here. And now he punctured the septum and now introduced the guide catheter inside the left atrium. Through this guide catheter, he will introduce everything inside the left atrium. And we need to have this view in hand every now and then, because sometimes the interventionist will need to push the whole system in or pull the whole system out. And in that case, we have to show him how much guide catheter he has inside the left atrium. Otherwise, if he pulled it too much outside, he can lose the septal puncture and the guide catheter will fall into the right side. This is the equivalent view using 3D-TEE. You can see the left atrial view. You can see the guide catheter is coming from the right side, puncturing the septum and standing at the roof of the left atrium. Mitral valve is here. This is the comedian ridge, below which left atrial appendage, above which left upper pulmonary vein. Now he will try, the interventionist will try to cannulate or wire the pulmonary vein. You can show him this on direct vision by some tilting, even like what I'll do now, to show him the appendage, comedian ridge, left upper pulmonary vein on direct vision, to let him know that this is the appendage, don't go there, and this is the pulmonary vein, go there. And this is what he did here. He wired the pulmonary vein. Now he introduced the sheath with the clip in closed position above the comedian ridge. Again, this is the equivalent to using 3D-TEE. The guide catheter here was pulled to this point. The sheath is here, and this is the clip in closed position. The two arms are seen here above the comedian ridge. Now he will bend the sheath to point towards the mitral valve as planned, like here. And now he will open the arms of the clip, and we have to make sure that the clip is really perpendicular to both leaflets. If you are using 2D only, you have these views to show the long axis view, which will show you the anterior posterior leaflet, and you have to see both arms of the clip here. And then the commissural view, and in that view, you have to see one side of the clip. That means the clip is really perpendicular. If you are using X-plane, that can be done like this. Start by the commissural view, put your line, and you'll see the two arms in relation to the leaflets. If you are using 3D, it is much easier done and appreciated, because everybody will say immediately that this clip is not perpendicular to both leaflets. That clip needs a little bit of anti-clockwise rotation, and this is what he did. Very easily appreciated and then monitored using 3D-TEE. And even motion from side to side is much easier appreciated if you are using 3D-TEE guidance. As you noticed here, the clip is moving, the sheath is moving, the heart is beating, the patient is in mechanical ventilation breathing, and I did not change my view. Still, I can see everything from one view. But remember that if you are using two-dimensional TEE, because it's 2D, very thin slice of imaging, if this clip moved few millimeters away from my view, I will lose it, and then I will ask the interventionist, please stop here, let me get you back into my screen, and that will consume more time, more fluoroscopy exposure as well. Then I will put color, and then he will check the trajectory or the behavior of the clip if you pushed it inside the left ventricle. Now the clip is inside the left ventricle in both views. This is a 2D step, and then I will put color. Putting color here is very important, and this is a very satisfactory view because now I know that the clip is really heading towards the regurgitant orifice, and that means grasping here will most likely affect the mitral regurgitation. This is a grasping trial, Grabber's down, arms up, anterior leaflet was in, but posterior leaflet was out. This is the failed grasping trial. So release and grasp again, Grabber's down, arms up, anterior leaflet is in, posterior leaflet is in, successful grasp. After that, you have to assess the anatomical insertion of the leaflets inside the clip, and then by color, you can appreciate how much mitral regurgitation is remaining, and also the gradient. As we said, we shouldn't have a gradient of 5 millimeters of mercury or more. So that patient had 3 millimeters of mercury and significant mitral regurgitation remaining. We decided to put another clip just lateral to the first one. With the guide catheter still in place, now the mitral valve became double orifice. Left atrial view, we decided to insert another clip into the left atrium. Again, perpendicularity and positioning the same way we did for the first clip. Grasping of the second clip, you can notice the stasis. This patient had atrial fibrillation, very liable to stasis. That was optimized using the heparin. And then with the sheath still connected to the mitral clip, we assess the anatomical insertion, we assess the gradient, we assess the remaining or residual mitral regurgitation. If you are happy, you can ask the interventionist to release. And this is what he will do. As I said in the very beginning, the metal part that was inside the clip is a needle, and we have to monitor the behavior of this needle during pulling back. And that is easily done using 3-dimensional TE. It's one view, but again, in order to see this by 2D, you have to monitor few millimeters by few millimeters of motion. Otherwise, this needle can hit any part of the left atrial cavity and causing perforation and tamponade. That was the final result for this particular patient from the lung axis and full chamber view. A very satisfactory result for mitral regurgitation reduction. And this is the surgical view of the mitral valve after clipping. You can see 2 orifices. Now I'm looking from the left ventricular aspect. You can see the 2 orifices of the mitral valve with the 2 clips side by side. And this is the LVOT. You can notice something that I did not go to the stomach to get short axis views for the mitral valve. Everybody will know that if you are using 2-dimensional TEE, in order to get short axis view for the mitral valve, you have to go to the transgastric views. But here, because I'm using 3D imaging, it is just rolling or moving the trackball from side to side or up and down. You can rotate the mitral valve volume and look from the left ventricle or from the left atrium without going to the stomach. Assessment by colorful volume as well. That was the patient before, and this is the patient after, with very satisfactory result for mitral regurgitation reduction. So in conclusion, 3D-TEE has an incremental role during MitraClip percutaneous therapy. It can create a common language between the echocardiographer and the interventionist by providing anatomically oriented views similar to what the interventionist is used to see. It really saves time. It can reduce radiation exposure, which is fluoroscopy time, and we have shown this in our paper. And it reduces the need to go to the stomach to get transgastric views. Thank you so much.
Thank you, Dr. Hani Mahmoud, for this presentation today. And I think for further question, the people which are having a look at this session can contact you or contact us. Thank you very much.
You're welcome.